Good morning. It's an honor to be here with you in that international platform. And today we just tell a simple story about the eye. Let's bond again, reattaching what shouldn't have left. So, Mrs. Sabiha Hassan is a 60 years old female. She's come for the ophthalmological unit seeking for cataract surgery. She is diabetic before 5 years old. Her HbA1c is 7 and it's controlled. Okay. Everything is normal. Her left eye have a nuclear sclerosis, 3, and her visual acuity is 660 corrected to 612. Everything is normal, the fundus is okay, we do the biometry and we go for the surgery. During the phaco surgery, everything is perfect and we do the ordinary cataract surgery, but in the irrigation aspiration step, unfortunately, there is no video. I encounter a cement membrane detachment, and actually it's my fault. When I drop the IA probe, I fortunately touch the cement membrane. So directly I start to refold the cement membrane with the cannula and then decompress the anterior chamber. I want the cement membrane to attach to the iris to refold the cement membrane, and then I inject the air from the side port and I complete the surgery. But in the first day, this is the picture of my patient. And I swear I can feel my heart broken at that time. So I do the visual acuity is 636 and there is no correction. And this is the mass. This is the anterior segment OCT, and I have a large cement membrane detachment, maybe reached to the zone 1 to the pupil plane, and it's more than 1 mm in the height and non-planar. So what I do? I directly decide to take the patient again to the operation room and to re-inject an air bubble. And this is the same video. It's just like this video. We take an air bubble. I fill the anterior chamber. The whole anterior chamber is filled, waiting for 4 to 5 minutes, and then decompress the anterior chamber and bring just 50% of the air bubble. It's just the same in that video. So after 3 days, the visual acuity is 624 and the corrected is also, it's not that much better, and still there is the cement membrane detachment. And at this time, I'm just confused. Can I do an rebubble of air or I go for gas? Actually, my patient is in the rural area. She is old patient and she can't go too much visits for the ophthalmologist. So I said, why not retain the air bubble again? So I took her again and do an air bubble again and follow for the next visit after a few days. And this is the results. It's a clear cornea. The cement is fully reattached and the visual acuity is 6.6. She's happy, I'm happy, and everything is do well in just 2 air bubble. After that, let's take a few notes about the cement membrane detachment. Actually, it's first encountered in 1928 by Samuel Brand, and the most common cause is a surgical during the cataract surgery. Some patients may have also anatomical predisposition like cement DM or other disease. I will focus on the surgical cement membrane detachment, and as incidence, the most common step when the cement membrane detachment occur actually is the incision related. About 55% of the cases can occur in this step. Irrigation aspiration is 35, hydrodissection maybe 5.6, capsulorhexis and IOL implantation is about 4. All over, the percentage of cement membrane detachment in phaco surgeries, it's not that much, 0.5 to 0.8, while in the extracapsular cataract extraction, surprisingly, it's more, about 2.6, and the large percent for the small incision cataract surgery, which is about 11 to 42. And maybe that because we do a tunnel through the stroma of the cornea and much manipulation to the cement membrane. The causes, it's many like surgical instrument during. It's finished? All right.
Yeah, time is finished, Dr. Marwa.
Okay.
So
I just want to see the face of the patient when she happy. I have a picture for her. Can we just
can you ask them to?
just the last picture? I'm sorry, I want to. It's too much. But the last picture is the most important one. Let's see. Thank you. She's happy. I'm happy, and a simple thing, just. Actually, I don't have time. I do comparison between the gas and air, and why I use air twice. Actually, the success rate for gas and air is too much comparable. For air, it's about 95, while in the gas, it's 90 to 100. Otherwise, the gas, there is increased IOP, the visual, need more time to be rehabilitated. So I choose an air bubble again. Thank you so much.
Thank you.
Thank you. So, this is a competitive session, and if you have just 5 minutes, you should have, only 10 slides.
Yes.
Anyway, I wanted to ask, Mark Twain said, if you do the same thing again and again, you will get the same result.
Yes.
So, after you had a problem on table and you have put the bubble,
Yes.
and next time you saw that the patient didn't do well, you again did the same thing.
Yes.
Anyway, you did the same thing and you got the same result. Now, before you took up the patient for the third surgery, what type of due diligence we could have done so that we didn't have to go for the fourth surgery? So have you gone back and thought about this case? What could I have done differently so that I didn't have to take the patient 4 times to the OT and I could have done something different or better? Or
Yes.
how we should approach a case? It's general question for surgeons, like how
Yes.
should we approach a case where we have done something, it didn't work, we have done something, it didn't work. Now what should be the next step
Yes.
before we do the same thing?
Yes, for me, I see the gas and air. This is my 2 plans. Actually, maybe the facilities there in the hospital and my patient is far away from the hospital. I'm afraid I put for her sulfur hexafluoride or perfluorocarbon. Maybe there's increased intraocular pressure. It's have a long time, maybe 14 days until it's completely gone, where the air bubble just take 3 days and I'm feeling comfortable. There is no IOP elevation. That's it. But yes, I take a risk. I think that.
Yeah, no, why I'm coming to this, because I'm a mentor and I just wanted to highlight this point. I had somebody who, did a tarsorrhaphy and I'm quality in charge, and I got that report that this was the 10th tarsorrhaphy. 10th tarsorrhaphy in 2-3 weeks, and every time they did, it opened. So I called the fellow and asked, what happened? He said, oh, it has happened 9 times. So it's like, it's always opening. I said, if it's always opening, why did you do the 10th time? Why didn't you say, I will not do this surgery? What's the point in doing and say it happened 10 times? So my point is that at least I have learned from my mentors that if this happens first time, okay, second time, then stop. Ask others how it will happen. Go back to literature. Go back to the net. Ask other people. Find out, look at that video again and again and find out where could I have changed something. Because if we don't do this step, we'll land into the same problem again. So I'm just saying today resources are available, and before we take up another time, we should try to check, is there any other technique available? In that tarsorrhaphy case, ultimately I found that we could do a skin graft, and that was a more serious procedure, but at least it's not like, patient is going to OT 10 times. So that's just a lesson I want to share.
Yes, thank you.
Please do due diligence before taking patient back to the OT. We can do 100 times, but it's better to, and then look at your video again and think little about the patient than just do the same thing. Thank you very much.
Thank you so much.
Thank you, Dr. Marwa. Thank you. So that's the end of our presenters, and I would like judges, if you have any comments.
Actually, I do agree with Madam regarding redoing the same technique and the same management many times, even if it's failed first time. So we need to think differently and to manage things differently. And the importance of having the recording of the intervention, it is priceless. It is very important to show and to show it again, so we can put the finger on the bad step, the wrong thing, and to correct it, and maybe to manage it properly. Thank you.